Greetings, everyone. For the purpose of keeping it to 12 minutes in our video presentation, how I do it, endoscopic fusion, we would like to use the video presentation pre-recorded. I'm Dr. Pang Hong Wu. This is my conflict of interest. Some of them are relevant to the topic today. I'm currently a spine surgeon, orthopedic spine surgeon practicing in Mount Elizabeth Hospital and Mount Elizabeth Novena. I have a visiting consultant post and in several government hospitals. Currently, I do most of my cases as endoscopic spine surgery. So this is a video presentation. I will cut to the chase. Let's go on to how do we do left L45 endoscopic fusion. So I started doing endoscopic fusion in 2020, and this is one of the cases done about a year after I practiced. But it is nevertheless one of the classical case, L45 spondylolisthesis with severe spinal stenosis. And we position the patient in a prone position on ProAxis table. We mark the levels. For the left L45 approach, we mark at where we want to put our pedicles through at the left L45. And this is a video showing how it's performed. We first dock at the spinal laminar junction, and then we expose the facet joint with the large radio frequency. And then we identify the spinal laminar junction, Wood's point, and then the lateral part of the facet joint between the superior and inferior articular facet, Kim's point in our paper. So after we drill and dissect, we realize we can find that this is a spinal laminar junction, and then you can find the interlaminar space. Checking II shows that is the correct area. And on the lateral view, we can see that it is on the facet joint. So we will resect that area from Kim's point to Wood's point, like this. So we perform the inferior articular process vasectomy. Typically, we use a chisel to do that. If we do uniportal endoscope, then we can use the drill to do this part of the surgery. Advantage of biportal infusion in this case will be that we can harvest bigger pieces of bone. And you can see that after we harvest that, we can see the interlaminar space, and large pieces of bone can be used to harvest and use as a fusion material. And then we, as you can see earlier on, severe spinal stenosis. So we do a thorough bilateral decompression. These are contralateral lateral nerve roots, and at this space you can see good decompression was performed. And now, after we have done the decompression, then we can do a superior articular process resection and remove the remaining flavum on the left side, ipsilateral side. After the flavum is removed, we can see that this space quite clearly. The beauty of endoscopic fusion is that you can visualize very clearly where's the nerve root in relationship to the disc, where's exactly the disc, and also to have less bleeding because of thorough hemostasis. Significant bleeding will obstruct endoscopic view, so usually we would not let that happen. So we will stop the bleeding before we proceed on to the next steps. After that, we can use the shaver that's available in whichever instrument company that you would prefer to use your cage with. So then we can do a thorough disc preparation. Throughout the process, you will be visualizing the traversing nerve root. In some of the cases where we are doing a far lateral approach, then we can also visualize the exiting nerve root. So then using the blunt instrument, we can prepare the end plate. Advantage of endoscopic fusion is that you can see the end plate preparation very clearly. I find that using just dilators alone, after we use dilators and curettes to prepare end plate, we find that there's still a lot of this remaining. So we tend to use more blunt instrumentation as well to prepare the end plate clearly before we insert the dilator troughs, bone graft, and cage. Subsequently, then we will be inserting the bone graft and then the cage, and the cage insertion is done using specialized retractor. So these are the II images for the instrumentation with the percutaneous pedicle screw. It can be done with X-ray or O-arm. For the right side, we also use the pedicle, that's the landmark. So typically, we also will be using slightly lower ports than the left. The main aim is that on the right hand, we'll have a direct trajectory to guide the cage in, as you can see from this case of the video running. The advantage on endoscopic surgery is that you can actually visualize the big bone pieces that can be removed in the instrumentation. So you can see the inferior articular process can be removed in chunks. That can be used as a bone for autograft. And then we subsequently can insert the typical cages that we use in fusion, as well as trowels, dilators, and bone harvester can be used as bone graft. And you can see the post-op 2 week can walk well, and yeah, this patient can walk around 10,000 steps 2 weeks post-op, so it's very good, the result. This we have highlighted from the right side approach, the portal is a bit lower. You can, the main aim is the right hand can go direct to the disc space, and then you can have an easier time to insert the cage. You can see in this surgery, you can see the disc space quite clearly, and it's pretty comfortable in doing this prep as well as that of the trowel insertion of cage. Dilators can be inserted, and then also the space thoroughly prepared. I find that using just typical shavers, dilators, and the curette, there's still quite a lot of this left in behind, so we tend to use some blunt instrument before we insert the cage in. So these are some pictures of the cage insertion. After we are familiar with the left side and the right side unilateral bipolar endoscopic fusion, then we typically start with 1 level, 2 level, then 3 levels, and after a number of years, then we have come to a patient like this, 63 years old, back pain for 2 years, walking with instability, and then also have a bilateral leg pain left more than right. If you feel weak and have difficulty climbing staircase, and then you can see there's some numbness in the leg, and what is predominant is that he's walking with unsteady gait, a lot of numbness in the feet. And we can see that in the MRI, besides the left side L2 to S1, various severe spinal stenosis in the foramen as well as lateral recess. We also can see in some of the cuts that in the T11-12, there is a thoracic spinal stenosis with myelomalacia. Bear in mind, it's a lumbar MRI, so after we have obtained the cuts of the lumbar MRI, where we show L2 to S1 spinal stenosis, we also go ahead with CT scan as well as thoracic MRI. CT scan shows, as well as X-ray shows, there is a coronal deformity on the right side. Is a coronally deformed at the L45, L5S1, and then the L23, L34 is more of coronally tilted towards the left. It is CT-guided nerve block, and there's a relief of pain for 1 month. And the patient was given options of conservative treatment or surgery. In surgery, then we did about discuss open L2 to S1, open or a corrected deformity, open T10 to pelvis, and then whether we do an OLIF lateral approach, which has large cages, minimally invasive, or a minimally invasive version. For me, is the UBE fusion. After various discussion, the patient decided for minimally invasive option, which is for me UBE endoscopic fusion. And then we have an issue of the thoracic myelopathy, and we did MRI. The rest of the thoracic spine is clear, but T11-12, there is severe spinal stenosis with myelomalacia. So this is an opportunity where we can clear all this stenosis at one shot because of the versatility of biportal endoscopy. And we can, through our experience, also insert even very much larger cages. For these purposes, because of coronal tube, we wanted to correct it with T-lip cages. So we started out with T11-12 right side approach. We compress the thoracic spine, then I do a right stage 2 is a right L4 to S1 UBE fusion. Then we switch over to a left L2 to L4 UBE fusion. So this is the intra-op pictures. We count the level at T11-12. And then we did the spinal endoscopy to decompress the spine. You can see the MRI shows a significant compression of the nerve and spinal cord rather in T11-12. So we did an endoscopic decompression. in this case. These are the markings. We mark all the way from T11 to L5. And then we did the UB decompression first, T11, 12. From the right side, we can remove the flavum of both sides, as well as that of the facet joint. I find why I stand on the right side is that there's extensive facet hypertrophy on the right side. Unlike lumbar spine, don't really like doing crossing over of the spinal cord to decompress the opposite side with the worry of touching the spinal cord. So we tend to decompress starting on the right. So we can also remove the central and lateral recess stenosis of the left side. You can see that I'm removing the left side flavum now. The left side stenosis is moderate, so there's less emphasis of decompression. Nevertheless, we did compress and then went on to do a fusion, starting from the right side L5S1, then the right side L45, then we do the left side L34, followed by finally L23. So these are the post-op results. The patient has significant improvement in terms of mobility. With post-op day 2, he actually walked on post-op day 1 already. Post-op day 2, we tried staircase. He managed it quite well. And the interesting thing is that the post-op HB just have decreased in 1 gram after kind of 5-level surgeries. So in terms of blood loss, I think endoscopic surgery is quite superior to many ways to prevent blood loss intraoperatively. Part of the reason is there's any loss of blood will lead to poor visualization, so we tend to stop as soon as there's any bleeding point. So there are questions throughout my practice on the post-op fusion results. In my practice, I typically do a 1-year post-op CT scan in the lumbar spine, and it shows that 95% of my patient feels, minus those who have lost to follow-up, most of our patient feels at 1 year, 95% of the time. And we have published in various journals of our results. The main conclusion published by the Jin Song Kim's group in conclusion is that they endoscopic fusion have smaller incisions, reduce blood loss, faster recovery, shorter hospital stays, and then we need more studies, additional investigation through extensive trial to see the long-term results. In ours and in our collaborators with Korean as well as our own centers, we have done our 2 years results and they have good fusion rates. We look forward to more long-term data from various sources to evaluate this established technique. Thank you.